Hello, today we're going to be discussing ECGs worse than the STEMI. We're talking about the cardiac type of outbreak and it masquerades. This ECG masquerades as an S elevation MI, but it's not one. We are going to decode this classic ECG trap, and it's worse than an SMI because even the best clinicians can miss this. Now, what is this? This condition is also known as, okay, just going through my slides to make sure I have the proper one. But this condition is also known as broken heart syndrome, and it is real, it's documented. It's been There's several cases that have happened all through. The first time it was um, documented by Dr. Hikaru Sato in Japan, and it's named after a Japanese octopus trap because that's what the stunned left ventricle looks like on an echo. It has a narrow neck with a round balloon apex. And we are going to be discussing all about it today. The troponins may or may not be raised. We've seen several cases where it's been triggered by emotional or physical stress, and you could have ST elevation in your anterior leads. Now, I've already mentioned that it was discovered by Dr. Hikaru Sato, and Takotsubo is a Japanese word that talks for an octopus trap. It is acute, it is reversible, and it can cause left ventricular dysfunction. It mimics an MI, but it has clean coronary artery. So this is the kind of ECG that you would activate. You will activate in 2 seconds. Sorry, I I had to take care of some bits of distractions. But anyways, Takotsubo cardiomyopathy is acute, is reversible. This is the type that you would activate your cath lab for, and they would go into the cath lab and check all the arteries, and the arteries would all look clean and clear. And so as you can see, this is the what it would look like on an echo. You can see the classic shape of the ventricle and how it balloons out, right? And you can see some would also liken it to this pot of jar that seems to have some narrowing at the neck. The rope at the neck would, it's just to describe the shape that the echocardiography report would, the echocardiogram images would show. And yeah, you can see a normal art. In a normal art, this is the shape of the left ventricle. But in Takotsubo cardiomyopathy, the left ventricle becomes similar to the octopus trap, right? And so you can see that the apex does not contract, but the base contracts. And this is what we call apical ballooning. And it's called Takotsubo, Japanese octopus. And it has even fooled early interventional cardiologists in the past. You have interventional cardiologists go in to for the PCI thinking that this is an MI that they need to intervene for, but at the end of the day it is just Takotsubo. So who gets this? It does affect 90% of postmenopausal women aged 58 to 75. It's scary, isn't it? Yes, it can be triggered by intense emotional or physical stress, arguments, trauma, bereavement, sometimes even extreme happiness. And yet it's usually reversible, but not always harmless. Some develop left ventricular obstruction, some develop arrhythmias, even cardiogenic shock, and some, what 1 in 5 patients will have a complication. So spotting it early does matter. So what's actually going on? A massive catecholamine surge stuns the myocardium. So it causes um, temporary dysfunction in the apex of the left ventricle, not because of a blocked artery, but because of stress-induced toxicity. And the result is that the heart balloons out like an octopus trap. And unlike ischemic wall motion defects, where you have which follows coronary territories, this stunning does not, so it does not really. And where in STEMA you would find this ST elevations occurring in contiguous leads. This might not necessarily be the case with Takotsubo because it's just this catecholamine toxicity surge on the myocardial tissue. So the patient will come in looking like a textbook MI, chest pain, shortness of breath, palpitations, maybe even syncope. But here's the twist. They often lack traditional cardiovascular risk factors. No diabetes, no hypertension, no pre-angina, just emotional stress or illness before the event. And that's why you will need to think outside the MI box because Takotsubo does not play around by coronary rules. And here you will see ST elevation. I might get my pen annotator out for this. Here you will see ST elevation here. You can see ST elevation in almost all the leads, in fact. ST elevation here. And this is what I meant by it not being just in contiguous leads. So you would think, oh, is this an anterior STEMI? Is this an inferior STEMI? Or is this a lateral STEMI, right? Is this a lateral STEMI? And in fact, you will be worried, and you can see what looks like an ST depression also here, and so you will be worried and say, what's going on. Sometimes you could have a prolonged QT interval, right? You could have a prolonged QT interval, but the troponins might be elevated, but not often sky high as you'll find in an ST elevation MI. With your ST elevation MI, sometimes you repeat the trops and you're even doubling, tripling. In a Takotsubo, the S elevation, if elevated, is only just mildly high, and it doesn't get that, you don't get that rapid upshoot many times. And the angiogram we've said will be clean. The echo will give you the telltale apical ballooning, and that's why it's the gold standard, or almost the gold standard with echocardiography. Echocardiography is the most appropriate investigation for Takotsubo. But you must consider other differentials, because the other differentials are potentially dangerous and life-threatening, like your ST elevation, obviously, myocarditis, pericarditis, pulmonary embolism, even pheochromocytoma. MRI can help confirm reversible injury and rule out scarring, right? In this ECG, you can find out that there is no reciprocal ST depression, which is one of the ECG clues for your ST elevation MI. You would have reciprocal changes, but this is not absent. This is absent, I mean. Now, the diagnosis and differentials. Now, we've talked about that. We've talked about this. The treatment strategies, there are two treatment pathways here depending on how stable the patient is. If they are stable hemodynamically, you're looking at supportive care, stress reduction, ACE inhibitors, careful beta blockers, DVT prophylaxis. However, if they're hemodynamically unstable and there's left ventricular output obstruction, you're avoiding inotropes because they will make it worse. You're giving IV fluids cautiously, and you're giving beta blockers. In extreme cases, you might want to give some intra-apical ballooning, and you just don't assume reassure and discharge just because you think this is Takotsubo, because some of these patients can crash fast. Now let's look at this case scenario of an 85-year-old woman. Will came in with vague unease and thirst, no classical angina. The ECG was showing some evolving T-wave inversions. Trops were at 4.2. Echo showed left ventricular output obstruction. She was treated with cautious fluids and given intraapical ballooning. She developed a pericardial effusion, a complication of both the disease and the support she received. And the diagnosis was Takotsubo. And that's how wild this ECG mimic can get, right? Because it's Takotsubo, but you did need to intervene. However, given the left ventricular output obstruction, you did need to intervene, and you had to go in with your intraapical ballooning. Now, let's land the plane. If you take nothing else away, just know that not every ST elevation is an MI. You know that if the coronaries are clean, you need to look closer. Think Takotsubo when there's stress, apical ballooning, an odd ECG. Also, if they don't have risk factors, right? If they don't have risk factors, consider, and they have ECG findings, consider Takotsubo as a strong differential. I'm trying to remember a particular thing yes, so IABP does stand for intra-aortic balloon pump, right? And it is used to in critical care cardiology to support a failing heart. And what it does is that it reduces the workload of the heart, improves coronary artery perfusion, increases cardiac output. And it's just a balloon inserted into the aorta, and it deflates during diastole. And you do give this as a measure for those with Takotsubo cardiomyopathy, with left ventricular output obstruction, or if they have massive MI with poor perfusion. So basically in Takotsubo, there might be nothing to do, but if they're hemodynamically stable, this might be the treatment to give. I just thought I'll explain a little bit of that because there's been the IABP trust, and I've been mentioning it without really explaining it. So I hope that does help. It's not helpful, however, if there's aortic dissection, aortic regurgitation, or severe peripheral vascular disease, and it is used to stabilize the patient in Takotsubo until their stunned heart recovers, right? Okay, thank you, and see you in the next presentation.